I think that if you have someone with HFpEF or unexplained left ventricular wall, increased left ventricular wall thickness, and they're over the age of 50, should always, I think, step back and think about what's the underlying cause of that. And so I think additional clues that might make you more suspicious if there's a history of things like carpal tunnel syndrome or other tendon ligamentous manifestations. We know that Black individuals have a higher propensity given the prevalence of the V122I variant. Um, I think that those would be some of the initial clues. Atrial fibrillation would be another one. Of course, that's common in overall as we age, but about 70% of ATTR patients will have atrial fibrillation. I mean, the emergence of non-invasive testing has really revolutionized the field. If you look back even just 10 years ago, it's democratized how or who can diagnose this condition. So, there's a limitation on the areas, the practices that have expertise to do biopsy. So, many places out in the community can do these scintigraphy scans. So it means that patients potentially could be diagnosed by more specialists as well as people in more areas, particularly out in the community. So that's been really, really beneficial. And I'd say the majority of cases can be diagnosed with scintigraphy rather than biopsy. So I think that that's one of the things that's galvanized the increase in diagnosis rate and what's led to this trend in diagnosing patients on average earlier. I mean, I still think the general cardiologist is probably the first place to diagnose patients. Someone presents with symptoms related to arrhythmia or heart failure, and they most commonly will be evaluated by a general cardiologist or referred to a general cardiologist. I think that there's a lot of interest in trying to move one step upstream and try to figure out are there ways to empower and give the tools to primary care physicians, orthopedic surgeons, and other specialists who might see these patients before they have heart failure. I think that that's the challenge there is that there's a little bit more heterogeneity in terms of how these patients present, and the initial manifestations can be pretty subtle. So I think that's where some automated screening tools might help to assist primary care physicians and other non-cardiologists to identify these patients sooner. Yeah, I mean, the if I had to say one piece of data, it'd be, about 1 in 6 patients over the age of 50 with HFpEF have underlying ATTR. And so, I think that a lot of clinicians see patients with heart failure. And if you think about 1 in 6 of them potentially having ATTR, that means everyone's seeing these patients, whether you know it or not. And in terms of misconceptions, I would say that the significant left ventricular wall thickness is a manifestation of ATTR, but many patients with earlier stage disease may have much more subtle thickening. And so, I think just having a low threshold to screen patients now that we have non-invasive testing. So there's not really much risk or downside to screening. So if you think they even have a small possibility of having this. Yeah, I think that that's going to be an interesting challenge. There's been a lot of development of AI-based screening tools for ECG and echocardiograms, and those have shown good accuracy in terms of identifying patients with a suspicion for ATTR. And so those things, they could ultimately be deployed widely in healthcare systems to identify patients. Like you alluded to in the question, how the system handles screening these patients and weeding out false positives is going to be a challenge. And so what I would say is I would suggest initially casting the net uh, in a targeted fashion towards the populations where they probably already have heart failure and we don't know they have ATTR. So I think identifying the ATTR patients who already have clinically symptomatic heart failure is the first priority because we know that these disease modifying therapies are quite effective, particularly the earlier manifestations of heart failure. And then I think beyond that, identifying those pre-symptomatic patients would be the ultimate goal, but it's going to take some time to figure out the best way to screen those patients um, pr- and do their testing in the health system. All to say that this is a really exciting time in the field for doctors, patients, and advocates because we have so many effective treatments. We have a way to diagnose this earlier and earlier. And I think the outcomes will continue to improve for this disease over the coming years.